Okay, another topic related to therapy is documentation. And the answer is, we're not going to spend much time on this because the answer to your question is yes, we have to do it. Sorry, we do. How often? The answer is always. What kind of documentation? It has to be data-based. No one's interested in your daily notes that might be in a SOAP format and might be in some other kind of a format. That is just kind of your opinion. You know, patient did okay today. That's not instructive, and that's not helpful, and it's not defensible. It has to be data-based. The patient did X amount of this. He was 80% correct in doing this, or he tried to do a task X number of times, or he didn't, or however, but data needs to be there. Defensible data, reliable data, meaningful data. It's a whole other topic. I'm sure you've addressed that in your seminars and clinical practicum and such. And it's at least as important in aphasia therapy as it is anyplace else. So the answer in documentation is, yep, we got to do it. We have to do it all the time. And it has to be done well. If you think for a second that even if no one else is asking for your data, suppose you have a private pay patient. It does happen sometimes. Family says, listen, you're the person we want. We're not covered. We don't care. We have money. We want you to do the therapy. Well, then I don't have to do documentation because no one's asking. And the answer is yes, you do. You have to do it for a lot of reasons. Probably the first one is because you just need to do it, because you need to maintain your routine of doing documentation. Second of all is if you think for a second that a month from now you're going to remember exactly how he did then, a month before, you're wrong. You're not going to remember specifics, and so the more specifics you put in there, the better you are. Third of all, at some point, someone's going to ask you, well, how did he do? And you're going to say, oh, in general, I think he's doing fine. That's not an answer. That's an answer that, again, the family can give. But you're the professional, and you need to be data-based. And so you need to do better than that. Okay. We're going to talk about a concept now of an aphasia team, and that we're not usually, and we shouldn't ever be, the only person working with this patient. The patient will do best when there is a team of professionals who are addressing the problems resulting from his brain damage, most often a stroke, but some kind of brain damage. So let's just see now who is on this team. Okay, and what I'm going to do now, there are no words here I think that you don't know, but I'm just going to describe briefly what their role is regarding our patient who has aphasia as well. Okay, the captain of the team is the doctor, whether you like it or not. That's who the captain of the team is. In most cases, the neurologist, the doctor, the type of doctor that we're talking about is a neurologist who is in charge of neurological issues, and clearly patient with aphasia by definition has a neurological issue. But then after the patient is neurologically stable and now they're into kind of long-term rehabilitation, often the physician who will take over has a specialty that's called physiatry, or he is or she is a physiatrist. A physiatrist specialty, if we looked it up in Webster, would say something about physical medicine and rehabilitation. And so they don't only work with stroke patients, although they do work with stroke patients, but they work with any patient who needs physical therapy and rehabilitation. So it may be spinal cord problems, it may be amputations, it might be any kind of a physical issue, often that has a neurological basis, but not necessarily. It could purely be orthopedic. And so often in a nursing home, for example, it may not be a neurologist, it may be a physiatrist. In a rehab center, it may be dealing with a physiatrist, not a neurologist. Again, I think that the issues for us are minimal, whether the person's a neurologist or a physiatrist, but it's something we should just know. Physical therapist is going to be an important part of a stroke patient's rehabilitation team if, in fact, they have physical problems. Marshall told us that In the fluent phasics, very often there is no physical therapist because the patient doesn't have physical problems. The only real problem they have as a result of a stroke is speech and language, in which case a lot of well, at least some of the people that we're going to be talking about now are not particularly involved. But the physical therapist will clearly be working with your patient, usually on issues of walking, lower extremities, which is a very fancy word for saying legs. Excuse me. We may or may not be interacting so much with the physical therapist, but often we will on team meetings where we're talking about patients. Occupational therapists are a little bit closer to where we are. Historically, occupational therapists did swallowing therapy before we kind of took that away from them, and we should have, and we did. But occupational therapists work with, again, upper extremities, or in English, that's arms and hands. And a lot of our patients will have difficulties with those, with appropriate use of arms and hands, not specifically for communication purposes, although they could be working on gripping a pencil or things of that nature, but use of it for activities of daily living, for cooking purposes, for shaving, for all kinds of other issues as well. Occupational therapists also will do kind of reality orientation work with the patient if that's indicated. And so again, they're a little bit closer to where we are, but again, they're not the same as us. Voc rehab therapists have a really important role, but unfortunately, not that much of a role with a patient who by definition has aphasia. A voc rehabilitation therapist is someone who will work with the person who has sustained a disability and assist them in re-entering the working world. If there's a possibility of re-entering their own working world, the one that they left, the jobs that they had before, or professions, what adaptations might be necessary, what adaptations might be available, so the person can do that. And if not, it may be trying to refocus on a different type of work. Unfortunately, almost all the phasics, this is not a practical issue. They're not going to be going back to work. Certainly not the kind of work they were doing before, and probably no work at all. It's a function of disability, it's a function of age, that these things typically are not real. But again, it might happen, so it's important that we know at least who they are. Recreational therapists usually are the nicest people in this whole team. They're the people who deal mostly in groups. They're critical in day centers, nursing homes, places like that. They will make sure that patients will know what day of the week it is and what month it is and what holidays are coming up. They will get patients busy doing things that are productive and that patients appreciate doing. So perhaps it might be needle pointing for a lady who used to do it, or perhaps never did, but now they have the time and they may have the ability to do that, or working on crossword puzzles or whatever. Anything that is recreational that keeps them busy and happy and productive, and so that they're not just sitting and doing nothing. Okay. Recreational therapists will sometimes ask you, so what can I expect them to do? Is it reasonable for them to be able to do a crossword puzzle or to do some kind of word games that we want to play or something like that? And so working with them is certainly something we will do. A neuropsychologist is a subspecialty of psychologists who specializes in neurological disorders. They're probably the closest to us in this whole list. But they're not dealing with communication per se. They're dealing with brain function in general. And so it's important for a neuropsychologist to be able to determine, is the patient being able to make reasonable judgments, assuming that they're able to take advantage of having all the information that they need to make a decision. I've often dealt with neuropsychologists on very practical issues like The patient was in the middle, the family was in the middle of negotiating purchase of a house. Can this patient still, is his signature worth anything? Can he make a decision about things like that? Is there a way that we can communicate with him so that he can do that? Should the family be declaring this patient legally incompetent so that their signature on a check is no longer valid? That might be an important thing to do. It sounds cruel, but sometimes it's what needs to be done until such a point, perhaps, when that could be reversed. Should the patient have his credit cards taken away from them? Should they be able to drive? There is laws about things like that, but again, your opinion, the neuropsychologist's opinion, is often involved in that. Dietitians often will work with the patients that we work with as well. Besides things like food preferences and low salt, low sugar, those are all very medical issues, but certainly texture issues that we might prescribe for our patient. We have this whole semester addressed the stroke patient as a communicatively impaired person, but this same person may also be a swallowing impaired person. We're not dealing with that this semester, but you are not two different people. No one's going to hire a speech pathologist to work with a person with aphasia who also has a swallowing problem and say, well, you'll do the swallowing and you'll do, another person will do the communication. You'll do both. And so the dietitian is part of that team as well. Social worker often is kind of the glue of the whole team, and they seem to know, and that it's part of their job, is to know all the important things about that patient. What kind of work did they do? What's the income level? What benefits do they have? Is there insurance that will work? Can they go to a nursing home? Is there money to cover that? Or is there money for them to continue rehabilitation in some other way? And so social workers are an important part of that team as well. The one person I'm leaving out, of course, is the speech language pathologist. And there's no one more important, obviously, than we are. And I don't need to say more about that, do I? Okay, we're going to stop here and we'll move on.